It's a very exciting time to be in sexual health. Recently, we've seen the approval of Flibanserin, or ADDI, the first and only FDA-approved drug for hypoactive sexual desire disorder. I'm your host, Dr. Michael Krychman, host of SexMD on ReachMD, and joining me today is Dr. Sheryl Kingsberg. Sheryl, tell us a little bit about your background and where you're from. It's really exciting. I know you've been involved with Flibanserin and ADDI for quite some time, and I know the viewers on SexMed are really interested in hearing about what you have to say.
Thank you, Michael, for inviting me on the show. And yes, I do think this is an exciting time for sexual health. I have, as a clinical psychologist, I've been involved in sexual health and sexual medicine for about 25 years. And I am involved both clinically, seeing women and couples who have a variety of sexual concerns. I've also been involved in teaching medical students and residents. And I've been involved in clinical research for about the last 15 years, starting early on with the intrinsic trials for the testosterone patch for hypoactive sexual desire disorder in postmenopausal women, and now fast-forwarding through Flibanserin and ADDI. So I was a clinical trial investigator for the phase 3 trials, both in pre- and postmenopausal women. So it's been very exciting to see that the FDA finally approved Flibanserin after almost a decade of research in this area, and it is probably the most studied drug of almost any kind in almost any area of medicine, with over 11,000 subjects in these Flibanserin trials. And to me, the approval of ADDI is probably the biggest step forward in women's health since the pill was approved in 1960. It's a long time coming.
That's great, Sheryl. I really appreciate the quick overview. Give us a little idea about the clinical endpoints and how that really translates into patients and what they say.
Sure. Well, to start with, Flibanserin, or now the brand name will be ADDI, is a non-hormonal treatment for HSDD. It is a daily pill, 100 milligrams, taken, actually I say daily, but it's taken nightly because one of the side effects is that it makes you sleepy. And it is essentially works to correct what we consider the neuropathology in HSDD of a dysregulation between the inhibitory and excitatory neurotransmitters in the prefrontal cortex. So essentially, it's a 5-HT1A agonist and a 2A antagonist. So keeping serotonin lower and increasing dopamine and norepinephrine. That's a theoretical mode of action. In the clinical trials, there were 3 large phase 3 clinical trials in premenopausal women. Initially, way back many years ago, the endpoints included a daily diary, and satisfying sexual events and distress, and the FSFI, the Female Sexual Function Index. Well, we learned fairly quickly that to ask women to rate their desire, particularly women who have no desire, on a daily basis was not a great endpoint. Number one, it causes subject fatigue, and there wasn't a great deal of compliance. And it's hard for women to really sort of microscopically zone in on what their desire is on a daily basis when we consider desire from more of a global gestalt perspective, sort of as a state. So it was essentially a failed endpoint. It was close to significant, but it did not meet statistical significance. And so when, at the time, Boehringer Ingelheim tried to get Flibanserin approved, because it did not meet that primary endpoint, it obviously did not. And so the FDA advisory committee at the time said, we think that there's promise for this drug, but you need to run a clinical trial with endpoints that actually meet statistical significance. So the more recent trial included a much better endpoint, which was the female sexual function desire endpoint, the desire subdomain endpoint, along with satisfying sexual events as the key primary endpoints with distress as a key secondary endpoint. And with those endpoints, in fact, Flibanserin showed statistically improved performance on all three endpoints. So that was the data that moved forward to get Flibanserin or Addie approved.
So, Sheryl, if I have you correct, it's not only about frequency. Women have improved desire. They also have decreased distress. And, I think it's quite important to remember that every woman herself will really define what desire is. And I think one of the important facets to remember is that the patient-reported outcomes were very positive in this case. If you're just tuning in, you're listening to Sex Med on ReachMD. I'm your host, Dr. Michael Krychman. I'm here with Dr. Sheryl Kingsberg. And for those of you who are unfamiliar with her, she is the Chief in Division of Behavioral Medicine, Department of OBGYN at McDonald Women's Hospital, University Hospital's Case Medical Center, Professor in Department of Reproductive Biology and Psychiatry, Case Western Reserve University School of Medicine. And Sheryl is one of the key opinion leaders and world experts on Flibanserin or Addie. So Sheryl, just to kind of give us a better overview, tell me a little bit about the benefit-risk ratio. And there's been all this hype about the alcohol and the driving study. Can you kind of just simplify those results for our listeners?
When the FDA is evaluating whether to approve a drug, they're certainly looking at not only the benefit but the risk. And one of the concerns about the benefit was, I think, sort of a misunderstanding of what the results suggested in terms of benefit. One of the points that they argued initially was that the benefit or the efficacy was modest, and therefore, compared to a risk, essentially no amount of risk was acceptable because the benefit was so modest. But what they really came to understand is that modest was actually very meaningful to women. And as you pointed out earlier, the Patient Global Index of Improvement really suggested that the efficacy that was shown was quite meaningful to patients or to the women in the trials. And what's important is looking at the concept of desire and the scale that was used. When you're looking at desire, you're not expecting women who are, for the most part, in long-term committed relationships and wanting to restore their desire. What they're wanting is to feel desire sometimes. And so what you see is the desire scale moved from absolutely no desire to having desire sometimes. And guess what? That's exactly what women want and expect in terms of restoration of their desire. If they had moved from no desire to having desire all the time, that was not actually a desired outcome. That would have suggested hypersexuality, and the FDA certainly wouldn't have wanted that, nor did women want or expect that. They wanted to restore their desire to some. So that's why modest was meaningful. Similarly, with the idea of satisfying sexual events, a lot of people kind of, sort of raise their eyebrows as, there wasn't a huge jump in the number of satisfying sexual events to suggest a great benefit. But in fact, women coming into clinical trials for hypoactive sexual desire disorder, for the most part, are in long-term committed relationships and are having satisfying sexual events at baseline. So when you can show an increase, and in this case there was a statistically significant increase from the Flibanserin group to the placebo, that's pretty impressive. And when you can then show also in the responders, the number of satisfying sexual events went up 5 to 8 more times per month, that's pretty impressive, showing that responders, if it's going to work, it's going to work well. So this is not just no benefit. On the risk side, which you were alluding to, were the fact that the most common side effects, I call them sort of the 7 dwarfs of side effects, were sleepy, made about 10% of women, sleepy, which is why it's dosed at bedtime. It created dizziness in some, headache in some, nausea in some. The worrisome side effects for the FDA were hypotension and syncope. And if you look at the rates of that, they're very low. You had 0.5% of either of the combined syncope and hypotension for the Flibanserin group, compared to 0.3 in the placebo group. So it was a very low rate and not significant, and not a great deal more than in the placebo group. Now, the other thing that worried the FDA is alcohol use. And so the company, Sprout, decided to do an extreme alcohol challenge, hoping that would address the worry about alcohol use with Flibanserin. And so, unfortunately, in this extreme challenge, it was hard to recruit women. So that was one complaint, because to ask women or anybody to complete the alcohol challenge was essentially asking people to drink 2 to 4 glasses of wine rapidly within 10 minutes on an empty stomach in the morning. And lots of the women that tried to be in this trial ended up throwing up, and so they couldn't keep the Flibanserin down. But in the 25 subjects who did complete the study, about 25% experienced dizziness, and therefore the FDA has contraindicated alcohol use of any kind while women are taking Flibanserin. To be fair, though, you have to realize that in the large phase 3 clinical trials, about 60% of these women, and so there's about 4,000 women in these phase 3 trials, rated themselves as casual drinkers, and so of those 60% who were drinking during their phase 3 trials, 6 to 12 months, there was no signal that alcohol was a problem. But for now, alcohol is contraindicated. The other worry for the FDA was driving, that they were worried about next day driving impairment because taking Flibanserin can make you sleepy. So the company, Sprout, conducted a driving study, a next day driving study, and in fact there was no statistical impairment in driving for the women on Flibanserin, and in fact they actually did better, and they drove better than women on placebo. So in this risk-benefit, there's clearly benefits and really a very modest risk.
Great, Sheryl. Thanks for that quick summary. And for full disclosure, I am a Flibanserin certified provider, and right now an additional level of surveillance is clinicians and pharmacists have to be certified. You have to go online, do a review of some slides, answer some questions, do an attestation, and then you can be certified, and pharmacists have to do appropriate counseling as well, and there's a specialized consent form that needs to be done. Sheryl, before we conclude, I just wanted to kind of get just a quick answer. There's been all this hype and I would say negative press about this medication, calling it the pink Viagra and what have you. We certainly know it works in a different fashion on a different mechanism. But as a sex therapist and as somebody who sees someone who's counseling, just give me a quick overview. I know this is not for everybody, and I think it's going to really increase the need for people to see therapists as well. Any idea what's going on, why people are so concerned and so afraid of this opportunity for women to discuss a potential medical treatment for their concerns of lower distressing libido?
Well, I do think that there's essentially a misguided feminism that the idea is that when you have a pharmacologic option as opposed to just diagnosing somebody with HSDD, which also carries a DSM diagnosis, and using psychotherapy as a treatment for the disorder, somehow making it a pharmacologic option somehow creates greater pathology or over medicalizes what has already been considered a medical condition. So I think that's a little misguided and creates a double standard there. But for me, the idea is, I'm never going to be without a job. There are always going to be women who really will benefit from psychotherapy to address low desire. But what the DSDS, the Decreased Sexual Desire Screener, will allow even a generalist who's not a sexual medicine expert to do is to tease out who might be an appropriate candidate for a pharmacologic option and who would better benefit from psychotherapy. And so I think it's relatively easy to do. And I think it will be very similar to how we understand depression. that some women will benefit from pharmacotherapy alone, some women will benefit from psychotherapy alone, and some women will actually benefit from the combination. And so it's not a one-size-fits-all. Not everybody will benefit from one or the other. And it really is just the idea of giving women options, that they can decide with their healthcare provider whether they want to try a pharmacologic option or psychotherapy. And guess what? If something doesn't work, women are smart. They're not going to continue with something that isn't helping them.
So, Sheryl, thank you so much for being with us today. We've run out of time, but always a pleasure and exciting opportunity to have you talk about such an important topic that you are so passionate about.
Thank you, Michael.
I'm Dr. Michael Krychman. You've been listening to Sex Med on ReachMD. Be sure to visit our website at reachmd.com/sexual medicine to download this segment and others in this series. And remember, sexual health is really general health.